Hi, I'm Dr. Stuart Goldberg from the John Thor Cancer Center from Hackensack, New Jersey. And I'm here with MDS.com. Sometimes I'm asked, when do I use lenalidomide? Lenalidomide is an oral agent that has shown efficacy in patients with MDS. It is FDA approved for patients who are transfusion dependent, who have low risk intermediate 1 MDS, and who harbor a 5q- deletion. The indication was based in part on a study by Dr. List reported in the New England Journal of Medicine, where the group found that patients who are transfusion dependent with a 5q- abnormality had nearly a 2/3 chance of becoming transfusion independent within 2 to 3 months, a dramatic response. In addition, some patients will have a 5q plus another abnormality, and once again, the agent was fairly effective. But in a patient who has 5q as part of a whole page of abnormalities, usually lenalidomide might not be my first choice. Some things that you should know: when you first start the medication, the agent will cause cytopenias, so we often will see a drop in white count and platelet count. So you have to monitor the patient fairly quickly. But usually patients will respond within the first 2 to 3 months, so we'll know if the drug is working. But what about the patient who comes in who's transfusion dependent, red cell transfusion dependent, but does not have a 5q? Well, off-label, sometimes the agent is used, in part because it's easy to give. It's an oral agent. Dr. Rosen and colleagues published in the journal Blood a couple of years ago that if a patient has normal cytogenetics, we might see about a 1/3 chance of having a response. Lower than the 5q, but still reasonable if the patient's only problem is anemia and we have 2 to 3 months to see if it's going to work. If I have a patient, however, who has severe thrombocytopenia, bad neutropenia, or high blasts, I don't think about this agent. And finally, could lenalidomide be used in the high-risk patient, the intermediate 2s and high-risk patients, since the agent is typically used in the lower-risk patients? Well, we don't have a lot of data in high-risk patients as single agent, and therefore it's typically not utilized, especially since we know that 5-azacitidine and decitabine, the hypomethylating agents in the high-risk patients, has shown benefit not only in making blood counts better, but also survival. But Dr. Mikhail Serkis and his group from Cleveland Clinic has thought that maybe lenalidomide can augment the effect of the hypomethylating agents, that 2 drugs may be better than 1. And in a study that he published, he did see that the combination was seen to be fairly effective, maybe higher than he expected. This has led to a large Cancer and Leukemia Group B, CLGB study that is ongoing, comparing 5-azacitidine alone with a combination of 5-azacitidine plus lenalidomide to see if lenalidomide will add to the effect. So for the most part, lenalidomide is used in my clinic for the patient who is transfusion dependent, who has a 5q-, and sometimes I'll use it if the patient is transfusion dependent and has normal cytogenetics, but has lower risk disease. And on study, I'm using it in combination with 5-azacitidine, but we'll have to see the results in these high-risk patients at a future date. For more information on this and other topics on MDS, check out managingmds.com.